Dr. Ketaki. She's moons younger to me, as you can see. She's also working in one of the municipal hospitals in Bombay, which is the BYL Nair Hospital. She's there. She's been there for many years now, and actually, she's been guided by my teacher. So I know she will be second to none. It will be an excellent session today, and even I know that these juniors who are in the academic teaching hospitals are abreast with all the latest up to date information in the world of pulmonary medicine, and you are in for a treat. So over to you, Ketki, and it's nice to see some familiar faces in the audience. Nice to see you, Rajeshri, and I hope it's not too basic for you, but the idea was to go back to basics and learn respiratory medicine the way we would have when we joined MBBS. So this is just a refresher and small things so that we pick up uh, signs and symptoms when we go to see patients bedside at home. Over to you, Kate.
Good evening, madam. Good evening, everyone. Hope I am audible.
Yes, doctor. A little more louder would be good.
Little more. Okay, okay. So, am I audible now?
Yes, perfect.
Yeah. First of all, thank you very much, dear madam, for giving me this opportunity and thinking me this able of taking a session here on such a prestigious forum. So today I'll be just sharing my knowledge about respiratory history taking and respiratory examination. I would just like to say that each and everything, whatever I'm going to share today has been taught to us by our dear madam. And it is madam's teaching and madam's coaching only that we follow, and we try to share our knowledge. So thank you very much, dear madam.
And that's not me, that's Dr. Jyotsna Joshi, who was the head of Department of the Nair Chest Medicine.
Yes, yes. So I'll share my screen. Yeah, so today's topic is respiratory examination. So first and foremost, why is it so important to start our session, our series of sessions with this topic today? So as we all know, the field of respiratory medicine is showing advances with regard to investigations, with regard to therapeutics each and every day. However, despite of all these advances, a meticulous history taking and clinical examination still forms the core of our clinical acumen. As we all know, each and every report, be it a radiological report, be it a pulmonary function report, or be it a histopathological report, each and every report in the end always is concluded with the line, kindly correlate clinically. So each and every investigation has to be based and has to be interpreted in the correct clinical context. Hence, our basics, that is our history taking and clinical examination skills, have to be thoroughly sound. So today, let us start the session with a history taking and then let us go on to clinical examination. So starting with respiratory history taking, first and foremost, before embarking on starting to take the history, few things are very, very important. That is, always form a rapport with your patient. So it is very important to address the patient by his or her full name. Try and make the patient comfortable. Position the patient in such a way that the patient is also comfortable, and so are you. And in the COVID era and also henceforth, always remember to maintain a good social distancing between you and your patient. Subsequently, then always before starting to take the cardinal symptoms, the first and foremost thing which is very important to understand is always stress to obtain and to elicit the correct duration of symptomatology. Because this is a key in which sometimes many of us try and make an error. Because whenever the patient comes to us, patient is agitated, patient is stressed. So whenever you ask, since when have you been unwell, patient generally try and correlate the symptoms to the latest period of the increasing or worsening of the symptoms. So patients always say that, yeah, I am unwell since last 2 days, or I am unwell since last 4 days. And here itself, sometimes our history gets little wavered. So it is very important to obtain the correct duration of symptomatology. It is very important to understand how long exactly the patient has been unwell. That includes his long-standing history as well as history of his acute worsening. So it is best to ask the patient, when have you been last in the perfect condition of your health? And how many years since you have been been unwell? So it is very important to obtain correct duration of history, especially in diseases such as long-standing airway diseases like bronchial asthma, COPD, or in progressive diseases such as interstitial lung disease. Next, after obtaining the correct duration of symptomatology, let us start and proceed with the cardinal symptoms of the respiratory system. These include three very important symptoms, that is cough, breathlessness, and chest pain. So starting with cough, why does cough happen? It is nothing but a protective reflex which involves forceful expulsion against a closed glottis. So whenever the patient complains of cough, understanding certain things are very important. First of all, whether it is a dry cough or whether it is a productive cough, because understanding the quality of cough helps us to get an idea about the likely etiology of the disease. For example, if the patient complains of dry cough, it is more likely indicator of involvement of respiratory components such as the pleura or involvement of the interstitium. Or if the patient complains of a productive cough, the patient is more likely to have a disease which involves his or her airways, or it involves the parenchyma. Again, this is not a golden rule. There are always exceptions to this rule, but a dry cough essentially most of the cases points towards an interstitial disease or a pleural disease, whereas a productive cough generally heads towards a airway disease or a parenchymal disease. Subsequently, understanding the nature of the expectoration is also important. Mucoid expectorations are generally seen in airway diseases such as bronchial asthma, COPD, or obliterative bronchiolitis. Purulent expectorations are generally seen in parenchymal diseases such as pneumonias or suppurative lung diseases such as lung abscesses. There are certain conditions in which the patient gives classical history of expectoration of copious amounts of sputum. So by copious amount of sputum, we mean at least 2 to 3 big mugfuls of sputum in a day. So in which are these conditions? So copious expectoration is found in conditions such as bronchiectasis, lung abscesses, and bronchopleural fistulas. Then subsequently, sometimes cough and expectoration might be associated with hemoptysis. So hemoptysis is coughing. To distinguish hemoptysis from hematemesis, in which the patient vomits out blood. So how do you distinguish that? First and foremost, in hemoptysis, generally the patient will have respiratory symptoms. The nature of the expectoration will be bright red, as against in hemoptysis, where there will be predominant abdominal symptoms associated with retching and vomiting, and the expectoration will be an altered color or coffee brown color. So hemoptysis is a very alarming sign, and it can be seen in number of conditions, starting with infective conditions, for example, pulmonary tuberculosis, acute bacterial pneumonias. It can be present in certain airway diseases like bronchiectasis. It can be present in lung malignancies. It can also be seen in certain conditions like foreign body in the airways. So always it is important to understand the duration of hemoptysis and also to quantify hemoptysis, whether it is streaky, whether it is around mild to moderate, that involves around 10 to 50 ml of blood in sputum, or whether it is massive, that is 100 ml in a single bout or 600 ml in a day. Because the management of hemoptysis differs on the quantification of hemoptysis. Next, we come to a next cardinal symptom, that is breathlessness. So breathlessness is, just in simple terms, it is an abnormal and uncomfortable awareness of one's own act of breathing. So when the patient complains of breathlessness, asking certain key questions to the patient is very important. So breathlessness can be episodic or breathlessness can be progressive. Episodic breathlessness is seen in certain conditions, for example, bronchial asthma or in bronchitis, whereas progressive breathlessness is seen in conditions such as chronic obstructive pulmonary disease or interstitial lung disease. So breathlessness is always quantified depending on the effort tolerance of the patient, or in clinical language, we can also use various classifications of breathlessness The commonest classification which we pulmonologists refer to is also called as the MMRC or Modified Medical Research Council classification. So in this, your breathlessness can be graded into 5 categories. So starting from grade 0 to grade 5. And how do you remember that easily? Grade 0. So always remember 0 is O. So 0 means breathlessness only, O for only on strenuous physical exercise. Now coming to the next grade, that is MMRC grade 1. So grade 1, remember the digit 1, that is on climbing uphill. The one finger points to climbing uphill. So grade 1 is breathlessness only on climbing uphill. Grade 2 can be remembered as 2 people walking together. So whenever 2 people are walking together and the patient lags behind his or her own peers, that is people approximately of the same age and also of the same sex. If patient is walking with his peers and patient lags behind, that is breathlessness of MMRC grade 2. Breathlessness of MMRC grade 3 can be remembered by 3 digits, that is 100. So breathlessness of MMRC grade 3 is breathlessness on walking 100 meters. So that is MMRC grade 3. And lastly, breathlessness grade 4, that is breathlessness at rest. That is, patient is so breathless that he is on his fours. You can remember it that way. And patient is too breathless to even sit up and sit down. So this is the MMRC grading of breathlessness. Breathlessness can be seen in various diseases. For example, airway diseases like bronchial asthma, COPD, pleural conditions like pleural effusions, acute conditions like acute pneumothorax, pulmonary thromboembolisms, or in lung malignancies also. Now coming to the next symptom, that is chest pain. Now chest pain per se is not a very classical symptom of our respiratory system, because to remember, in the entire respiratory system, there are only two parameters which are supplied by pain receptors, and that is your chest wall and that is your pleura. So you can easily remember that chest pain, which is related to the respiratory system, is always and always related to either the involvement of the pleura or the involvement of our chest wall and muscles. So involvement of pleura can happen in conditions like pleural effusions, pneumothorax. Sometimes there is inflammation of the parietal pleura in conditions such as acute pneumonias. The involvement of the chest wall can be seen in conditions like chest trauma, or it can be seen in malignancies with metastasis to the chest wall. So these are the only conditions in which the patient can have chest pain related to the respiratory symptom. So if your patient complains of chest pain, it is worthwhile to exclude these conditions. And if these are excluded, then the patient should be referred to exclude other non-respiratory causes of chest pain like cardiac or gastrointestinal. Next, coming to fever. The fever per se is a general symptom, but it can also be seen in many respiratory conditions. For example, infections such as bacterial pneumonias, fungal infections, viral infections, Mycobacterium tuberculosis. Fever can also be present in certain non-infectious conditions of the respiratory system. For example, connective tissue diseases in which there is a lot of inflammatory response going in. Fever can also be a symptom of conditions such as malignancies in which it is a part of the paraneoplastic syndrome. So, fever is the next cardinal symptom of your respiratory system. I'm sorry. Yeah. And sometimes there can be associated symptoms. For example, there can be puffiness of the face, there can be pedal edema. Now, these things are more commonly seen in associated conditions such as right heart failure. Sometimes patients with airway diseases have chronic hypoxia, because of which there is pulmonary hypertension leading to cor pulmonale and right heart failure. So, presence of pedal edema, facial puffiness, and increased breathlessness in any patient who has an underlying airway disease should always and always lead us to think about right heart failure in these patients. Am I audible? Can I move on?
Yes, yes, you are audible.
Next, we come to the clinical examination. So, clinical examination of the respiratory system starts with the general examination and then proceeds to respiratory system examination per se. So, always whenever we see the patient, it is important to make the patient comfortable, ask the patient to walk around a little and examine the patient as a whole. So, to start with, always we check the vital signs, which include the temperature, pulse, respiratory rate, blood pressure, and saturation, which is measured by pulse oximeter. So in that, respiratory rate, measurement of respiratory rate gives us an idea whether the patient has increased work of breathing or no. So it is important to make the patient comfortable. One hand should always be on the patient's abdomen, measuring the respiratory rate. Other hand with your wristwatch should be on the patient's hand, and we have to create an illusion as if we are checking for the pulse, so that we distract the patient and therefore calm down the patient. And then we have to measure the excursion of the abdomen and thus measure the patient's respiratory rate. After that, we can proceed on to certain general examination findings such as pallor, icterus, cyanosis, clubbing, lymphadenopathy, pedal edema, and examination of bones, joint, and spine. Now, I will not elaborate these in details because this is like examining any other patient or any other system. I will just focus on one important general examination finding, which is important for our respiratory system, which is clubbing. So now what exactly do you mean by clubbing? Clubbing is selective bulbous enlargement of the nail bed, and that happens because of proliferation of your subungual connective tissue. The underlying mechanisms of clubbing involve chronic hypoxia, or it happens due to opening of the AV anastomosis due to increased platelet-derived growth factors or vascular endothelial growth factors. So underlying mechanism is chronic hypoxia. Now, how do we elicit clubbing? Grade 1 clubbing may or may not be visible clinically. So it is generally elicited by a test which is known as fluctuation test, in which we feel for the bogginess of the nail bed. Grade 2 clubbing is something which is seen clinically, that is also called as Shamroth sign, in which, as shown in the diagram, you make the patient approximate the two thumbnails to each other. On the left side, we can see that the diamond-shaped window is very clearly seen because of presence of Lovibond's angle, whereas on the right side, this diamond-shaped window is obliterated. So that is known as Shamroth sign positive. Grade 3 clubbing is a clubbing which is very evident clinically, which is seen as rounding of the terminal ends of the nails, that is called as parrot beak or drumstick appearance. And grade 4 is associated with painful and tender enlargements of the long bones. And that happens because of subperiosteal new bone formation. That is also called as pulmonary hypertrophic osteoarthropathy. So here, as we can see, the left side shows us grade 3 clubbing. And this diagram, this X-ray shows us presence of subperiosteal new bone formation, that is pulmonary hypertrophic osteoarthropathy. Now we come to examination of the respiratory system. It always starts with the upper respiratory tract. Examining the upper respiratory tract is very important because it helps us to get an idea about the underlying disease. In respiratory system, there is a concept which is called as one airway, one disease, or it is also called as united airway hypothesis. What do we mean by that? It simply means that your respiratory system starts from your upper respiratory tract, that is your nose, and it ends at your bronchi. So it is entirely one airway. So it is one airway, one disease. So many times your conditions, for example, bronchial asthma is associated with the involvement of upper respiratory tract. Conditions such as your obstructive sleep apnea is also associated with involvement of your upper respiratory tract. Hence, we should always examine the upper respiratory system properly. Now, what all does your upper respiratory system examination involve? We should always examine the nasal cavity, whether there is any turbinate hypertrophy, whether there is any nasal discharge. Then you have to check for your sinus tenderness. Always remember to check for your oral hygiene, checking whether there are missing teeth, whether there are any tobacco stains, whether there is any gingival bleeding. All this is also important. And always remember to check for your mouth opening, because sometimes mouth opening or any conditions in which there is a restrictive lung disease. So all these things are relevant for your upper respiratory tract examination. Then we move on to the examination of your chest. But before that, understanding few things is very important. There is something which is called as surface marking of your lung lobes. Now our chest can be divided into broadly some areas. Why is it so important? Because on your clinical examination, if you get findings relevant to a particular area, those findings point towards disease of a particular lung area. As we all know, our right lung has 3 lobes and our left lung has 2 lobes. So how do you divide this? On the examination of the chest, as you can see, or anteriorly, the areas which correspond to your upper lobe are the intraclavicular area, the supramammary and the mammary area. The right middle lobe is a very small area, so even for clinical purposes, even if we ignore its existence, it is okay. So we can simply remember as areas of upper lobe correspond to intraclavicular, mammary, anteriorly, laterally it is axillary, and posteriorly it is suprascapular, upper interscapular areas. Again I repeat, areas corresponding to the upper lobe anteriorly are intraclavicular, mammary, laterally it is axillary, and posteriorly it is suprascapular and upper interscapular areas. So whenever we are getting any clinical findings in these areas, we can say that the pathological area is the upper lobe. Similarly, now if we are getting findings lower down, that is if we are getting findings in the inframammary area anteriorly, infraaxillary area laterally, and posteriorly in the lower interscapular and the intrascapular areas, then we can say that the pathology lies in the lower lobe areas. Again, I repeat, if we are getting findings in the inframammary area, in the infraaxillary area, and in the infrascapular and lower interscapular areas, then we can say that the pathology lies in the lower lobe areas. So now once we have understood this, let us now move on to the examination of the respiratory system. So chest examination is divided into 4 areas, IPPA, that is inspection, palpation, percussion, and auscultation. So before you start with inspection, it is always important to check the patient's respiratory rate, which we have already done in our general examination, to see the patient's respiratory rhythm, whether the rhythm is regular, whether the respiration is thoraco-abdominal or abdominothoracic, and whether the patient is having use of any accessory muscles. The use of accessory muscles of respiration can be seen in conditions in which patient is in respiratory distress. For example, can be COPD exacerbation, ILD exacerbation, in which patient will be seen to use his accessory muscles. There will be prominence of the sternocleidomastoid. There will be lower intercostal indrawing, also called as Hoover's sign positive. So all these signs indicate to labored breathing or respiratory distress. Then we come to inspection of the chest. So there are many things in inspection. So for ease of remembering, our madam has taught us in a very beautiful way, that is inspection can be remembered as there are total of 9 things. Now this 9 things can be divided as 3 general things, 3 anterior things, and 3 posterior things. So now what are these 3 general things? So 3 general things are, first and foremost, movements. So whether the movements are bilaterally equal or movements are reduced on a particular side. Now again I wish to highlight that there is nothing like increased movements. So movements are either bilaterally equal or the movements are reduced on a particular side. And always we should remember that the side which moves less is always the pathological side. Understanding this concept is very, very important, because all our future concepts or future findings will be interpreted in light of your movements. Because if there are unequal findings on 2 sides, then how do we know that the finding which is less is abnormal or the finding which is more is abnormal? So always it has to be correlated to your movements. So the side which size, shape, and symmetry of the chest. So movements, shape, and symmetry. Normal shape of the chest is ellipsoidal. Sometimes the chest shape can be altered. For example, in conditions such as COPD, in which there is lot of air trapping, the patient can have a barrel-shaped chest, in which the anterior-posterior diameter is much larger than the transverse diameter. And therefore, the chest looks as it is a barrel-shaped chest. Sometimes there can be other chest wall deformities. For example, there can be visible deformity of the sternum, that is called as pectus excavatum or the pectus carinatum, pigeon chest, Beckettic chest. But for clinical purposes, only if you remember barrel-shaped chest also, it is very, very important. Next, after movements, shape, second thing is symmetry. So whether both the sides of the chest are symmetrical, whether there is bulging on any side or whether there is flattening on any side. Now again, if there is unequal symmetry, one side is up, one side is down. How do we know whether this side is bulged? So whether the bulging is abnormal or is it the flattening which is abnormal? So again, this will depend on your movements. For example, if you see the sides abnormal, left side is flat and the right side is bulged or voluminous. And if the movements are reduced on the left, you say that there is flattening on the left side. If there are unequal movements, left side is flat and right side is bulged. And if the movements are reduced on the right, then right becomes the pathological side. Then you will not say that there is flattening on the left, but you will say that there is a bulging on the right. That is why your movements are very, very important. So now after seeing the three general signs, let us move on to the three anterior signs. So three anterior signs from top to bottom are trail sign, apex impulse and subcostal angle. So how do we check for trail sign? In inspection, we do not touch the patient. We just see the patient clinically. So trail sign is excessive or undue prominence of the sternocleidomastoid, and that happens to the side the trachea is shifted. But sternocleidomastoid on that side will be very, very prominent. Next thing is apex impulse. So apex impulse is simply the lowermost and outermost point of definite visible cardiac pulsation. So that is your apex impulse. Generally, it is seen in left fifth intercostal space in the midclavicular line. Now, shifting of apex impulse again also can give us an idea whether there is a volume loss or volume gain. Then we come to three posterior signs. Posteriorly, we again start from top to bottom. Sorry, in three anterior signs, after the apex impulse, there is a subcostal angle. So subcostal angle normally is acute. However, in certain conditions, for example, in chronic obstructive pulmonary diseases, when there is air trapping, the subcostal angle can be obtuse. Then we move on to three posterior signs. In three posterior signs, to start with, initially there is shoulder. Next thing is spine. To see whether the shoulders are at equal level or if one shoulder is up, that is elevated, or one shoulder is depressed. And how do we interpret that? Again, it is based on the side which moves less is the pathological side. If the shoulders are up and down, not at the same level, if this side is moving less, we will say that this shoulder is elevated. If this side is moving less, we will say that this particular shoulder is depressed. The next thing is spino-scapular distance. So spino-scapular distance, again, whether it is bilaterally equal on one side or it is reduced on the other side, again depending on your movements. So again, I'm highlighting the side that moves less is always the abnormal side. So as we can see here now, there is an undue prominence of the sternocleidomastoid. So that signifies that your trail sign is positive. And in the left-sided diagram, we can see the shoulder drooping on one side. Now we come to palpation. So in palpation, we can again remember it by the rule of palpation is 3 plus 1. That is three things which you have already seen on your inspection. You would like to confirm on palpation, and there is one additional thing. So I confirm the findings of inspection. Which finding will you like to confirm? First and foremost, most important thing is your movements. Now, in inspection, you have just visibly seen the patient. In palpation, you will touch the patient and appreciate which side is moving more or which side is moving less. Say, my hands move like that. So, it is my left hand is moving less than my right hand. So, movements are reduced on the left side. So, we will touch the patient and confirm our movements. Next thing is the trachea. So, we will put two fingers, that is one index finger and one ring finger on your medial border of the scapula, and we will roll down your middle finger down the trachea. Now, if my finger will automatically get deviated to the side to which the trachea is deviated. So, this is one method. Second is, I will try to insinuate my finger between the medial head of sternocleidomastoid and your clavicle and your medial end of clavicle, this way. Trachea is deviated to that side. So after checking for movements and checking for trachea, subsequently we will put our hand flat on the chest on the left side and check for your apex beat. So again, apex beat will be first palpated with the flat of your hand, then palpated with the ulnar border, and then palpated with the tip of the finger. Just like we have done in our medicine, we have learned in our UG medicine. After that, the next thing which I would like to check is tactile vocal premises. So three things which I have checked on inspection, I have confirmed on palpation, that is movements, trachea, and upextreme. And one additional thing is tactile vocal premises. So I will use the ulnar border of my hand. I will place it along costal spaces. Always start with the normal side. Normal side is the side which is moving properly, not the side which is moving less. So starting with the normal side, place the ulnar borders in consecutive intercostal spaces and ask the patient to say either 111, 999 and check for which is felt to the ulnar border of the hand. So tactile vocal premises can be interpreted as whether it is bilaterally equal, it is reduced on one particular side, or it is increased on any particular side. And lastly, we will check for rib crowd. This is particularly relevant in conditions which are associated with pleural thickening. Need not be checked in each and every patient. Shall I move on further? Thank you.
Yes, please.
Yeah, thank you. So now coming to percussion. So basically, before going on to percussion of the respiratory, the chest, I would just like to highlight few very important rules of percussion, which we all know, but sometimes in a hurried clinical practice, we may fail to implement them. So always the hand or the finger, which is placed flat on the chest wall, is your pleximeter, and the finger which percusses it is your plexor. So what are the rules? The finger should be held flat on the chest. It should be tightly opposed in the intercostal space, not like this. It should be placed like that, and other fingers have to be lifted up. Okay, so this is your position. After that, subsequently,
Dr. Ketaki,
like this. Yes.
Dr.
We
Ketaki,
lost you in between.
Yes. Hello.
Dr. Ketaki, we lost you in between. Can you repeat it once again?
Yeah. Am I audible and
Yes.
visible also? Yeah.
Yes.
So I just starting with percussion. Okay. The finger which is held opposed to the chest wall is the pleximeter. That is the middle finger of your whichever. If I am a right-handed person, I will place my left middle finger opposed to the chest wall, and the finger which is percussing it is your plexor. So this is the pleximeter and this is the plexor. So, and I am going to oppose the finger tightly with the chest wall. Other fingers will be lifted up to prevent the conduction of the sound. And then subsequently, I will percuss like this. So my movement should happen at the wrist joint and not at the elbow joint. This way, and the finger has to percuss it perpendicularly. Always percussion has to be parallel to the organ which we are trying to percuss, but the heart is an exception. In percussing the cardiac borders, we percuss perpendicular to the heart, with perpendicular to our heart. Next thing is percussion notes can be divided as resonant, impaired, and dull. Okay, and there is a tympanic note which is felt on your top space. So these are the general basic rules of percussion which we should always remember. So always warm your hands before touching the patient, make the patient comfortable, and then explain the patient whatever you're going to do. So percussion of the chest can be divided into topographical and tidal percussion. So topographical percussion, we will delineate the borders of the lung. So inferiorly, the right lung is bordered by your liver dullness. Left side, it is bordered by your trop space. So on the right side, I will start percussing from second intercostal space downwards till I feel a dull note. Now once I feel a dull note on the right side, I start percussing downwards. To confirm that it is a liver dullness, I will ask the patient to take a deep breath and hold his breath. And then I will again percuss. Why do I do this? Because I need to understand whether the dull note is due to the liver or it is due to any other pathology, for example, pleural effusion. So after taking a deep breath and holding What does that mean? That the lever has expressed. So that is the lever excursion. That is also called a tidal percussion. So it will change to a resonant note. Again, I will ask the patient to leave his breath. Again, the note will change to a dull note. So this is simply called as tidal percussion. So after checking for lever dullness, I will check for tidal percussion. Similarly, on the left side now, I will go on percussing 1-1 intercostal space downwards. Now here, after a resonant note, I will get a tympanic note. Tympanic note signifies that is a trop space, which is a semilunar area that overlies the fundus of the stomach. So trop space is a semilunar area which overlies fundus of the stomach. So it is bounded by your lung superiorly, by your rib cage inferiorly, by the left lobe of the liver laterally on the right side, and on the left side it is by the spleen. So that is your trop space. Then we will percuss the right and the left heart borders to delineate whether there is any shifting of the heart. And lastly, we will percuss on the lung fields. So while percussing on lung field, always remember to percuss consecutive intercostal spaces and always start with the normal side first. For example, if right side is normal side, left side is pathological, I will percuss 1-1 intercostal spaces comparing the normal side with the abnormal side. And your percussion notes can be divided into resonant, dull, or impaired. Now, what are the conditions which will resonant note will normally be present on the chest? What are the conditions in which we will get a dull note on the chest? The dull note can be seen in conditions, for example, pleural effusions, or it can be seen in conditions such as lung fibrosis, or in collapse, in which sometimes there is a collapse with an obstructed bronchus that could be due to an endobronchial mass. So any collapse, be it a collapse secondary to fibrosis due to old tuberculosis or collapse due to endobronchial obstruction, will give rise to a dull note. And sometimes in conditions, for example, pneumothorax, you may appreciate a hyperresonant note. But again, differentiating a resonant note from a hyperresonant note is very difficult clinically. So these are the various findings which we will get on your percussion. Next, we come to auscultation. Now, in auscultation, there are two broad type of breath sounds which we remember. Those are vesicular and bronchial. So, where are our sounds produced? Sounds are produced in the larger airways. So, they are bronchial in character. As we can see, the larger airways have bronchial breathing. Gradually, as the sound gets conducted through the alveoli, and by the time you hear it on the chest wall, dampening on the sound happens. And that is why you appreciate it as vesicular over the chest wall. So, sound which is produced in the trachea and large airways is a bronchial character, but by the time it goes down and we appreciate it over the chest wall, we understand that it is a vesicular kind of breathing. But sometimes this dampening does not happen. For example, in conditions like consolidation, as we can see, there is involvement of the upper lobe of the lung here. So, upper lobe of the lung is consolidated means solidified. And as we know, solid is a better conductor of sound. So, sound which is produced in the large airways is conducted as it is without any dampening and heard as bronchial. So, the same character of the sound which is here is appreciated over the chest wall. So, bronchial breath sounds are abnormal breath sounds which are produced because of solidification of the lung seen in conditions like consolidations or collapses. But here again, I need to highlight that by collapse, I mean it is a fibrotic collapse. That is a collapse with a patent bronchus. If we have a collapse that is obstructive collapse, there will be no conduction of sounds at all and we will appreciate absent breath sounds. So bronchial breath sounds are again of various characters. Tubular bronchial breath sounds are produced due to complete solidification of the lung parenchyma as seen in fibrotic collapses or consolidation. Sometimes, as we can see here, there is a large cavity which is superficial and irregularly walled or thick walled cavity. So in conditions like this, we can appreciate cavernous bronchial breath sounds. So we can remember cavity, cavernous. So cavernous bronchial breath sounds are seen in cavitary diseases which are superficial and thick walled cavities. Now coming to the next type of bronchial breath sounds, as we can see here, there is a cavity which is not thick walled, it is a thin walled cavity and it is a smooth walled cavity. So here sound undergoes multiple reflections in the cavity wall and that gives us a metallic intonation to the sound. and hence we can appreciate a quality of breath sound that is called as amphoric. So amphoric bronchial breathing can be seen either in a thin walled cavity, smooth walled cavity, or in conditions, for example, bronchopleural fistulas. Hydropneumothoracis with bronchopleural fistula. Again, the pleura can be said to be a one continuous smooth walled cavity. And if it is a bronchopleural fistula, there is conduction of the sound and we hear it as amphoric bronchial breath sound. Now here, in pleural effusion, what do we get? Logically speaking, since liquid is a better conductor than your air-filled alveoli, logically we should be getting bronchial breathing, but no. In pleural effusion, we get reduced breath sounds. And the reason behind this is formation of multiple interphases. Now, as sound gets conducted through your airways, initially it passes through air, then it passes through the collapsed lung, and then it passes through the fluid in your pleural cavity. So at various interphases, there is cutoff of the sound, and because of which we hear reduced breath sounds in your pleural effusion. So these are your breath sounds. Now adventitious sounds which are called as rhonchi and crackles. So how do we remember the difference? Rhonchi are continuous musical sounds. Queen, 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 queen. So for example, if a door that has not been oiled since long, and we open and close the wooden door, the kind of squeaking sound which the door makes, that kind of sound is rhonchi. So why are rhonchi produced? They are produced because of air which is passing through narrowed airways. If your airways are narrowed, air will have to pass through narrowed airways, and there is an increased lateral pressure which the airway exerts on the walls, and it sets the nearby airways into vibration. And this produces the squeaking sound which is called as rhonchi. Now coming to the second adventitious sound, that is crackles. So what are crackles? Basically, crackles are not continuous sounds. They are discontinuous, irregular sounds, and they are not musical. So crackles basically can be caused because of two mechanisms. First is either snap opening and closing of your airways. Okay, so this snap opening and closing of the airways produces fine crackles. They are also called as Velcro crackles. And why are they called as Velcro crackles? Because all of us must have sometimes used Velcro shoes sometimes in our life. Okay, the kind of sound that is generated by opening and closing the flap of the Velcro of our shoes. The sound is very similar to your fine crackles. So that is why they are also called as Velcro crackles. And they are seen in conditions like interstitial lung diseases, emphysema, or early stages of pulmonary edema. Next, coming to coarse crackles. So coarse crackles basically are produced due to bubbling of air through fluid-filled alveoli. So basically conditions which have a large amount of secretions in our airways, like bronchiectasis, or conditions in which the parenchyma is filled with secretions. For example, pneumonias. In that, we hear coarse crackles. In bronchiectasis, it has a peculiar character, and therefore it is also called a leathery crackles, because that is similar to use of a leathery shoe. That is, if you press the ground with a leathery shoe, the kind of sound that comes, that is similar to your coarse crackles. So again, tubular bronchial breathings are seen in cases like consolidation or collapse with the patent bronchus. Cavernous bronchial breath sounds are seen in cavity, and amphoric bronchial breathing is seen in large, smooth, thin-walled cavity or in bronchopleural fistulas. So now we have done with our inspection, palpation, percussion, and auscultation. So how do we decide now? We have certain clinical findings. So amalgamation of clinical findings and putting them into a proper decision chart is also very, very important. So again, we have to remember two things. There can be either unilateral disease or bilateral disease. What are the various bilateral diseases? There can be most commonly COPDs, interstitial lung diseases. So they will not have unilateral findings. Conditions like pneumonias, collapses, pleural effusions, pneumothoraces, all these will have unilateral findings. So again, side which moves less is always and always the pathological side. This we should remember. Next, coming to, there is something which is known as increased volume or volume gain, and something which is known as reduced volume or volume loss. What happens in certain conditions, for example, collapse,
Ketki, we lost you again.
Ma'am, hello?
Yeah, we lost you in between.
Yeah. So I start with the decision chart again. Hello?
Yes, you can.
Yeah. So again, after first and foremost, we have to decide whether it is unilateral disease or bilateral disease. Now, in case it is a unilateral disease, understanding whether the patient has volume loss or volume gain is important. There are certain conditions in which there is shrinkage of the lung parenchyma. It happens in conditions like fibrosis or conditions like collapsed obstructed bronchus, in which there is airlessness of the lung. So it will create all findings of shrinkage or volume loss. Trachea will be shifted to the same side. There will be flattening. There will be reduced spino-scapular distance. Shoulder will be drooped. Okay, so all these are signs of volume loss. On the other hand, there are certain, that is also called as pull phenomenon. The mediastinum is pulled to that side. Or in other conditions, sometimes conditions like pleural effusion, pneumothoracis, there is a volume gain, that there is a bulkiness or bulging of the same side of the chest. So that leads to something called as push phenomenon, which we have increased volume. So logically, what findings will we get? Volume is increased. So there will be bulge. There will be bulge of the chest wall. There will be elevated shoulder. There will be increased spino-scapular distance. There will be pushing of the trachea to the opposite side. So all these are volume gain findings. There are certain rare conditions. For example, if it is a unilateral lung consolidation that is not associated with collapse or a small pleural effusion, that time there will be no volume loss and no volume gain. There will be equal volume. But essentially, whenever it's a unilateral disease, more or less it is associated with either a decreased volume or increased volume. Decreased volume is seen in conditions like collapse, fibrosis, cavity, and there is a certain phenomenon which is called as pleural thickening. In long-standing pleural effusion, what tends to happen is sometimes the overlying pleura gets thickened, and because of which there is shrinkage of the lung on the same side. Associated with reduced breath sounds in conditions like pleural thickening. Then increased volume is seen in condition which there is some addition in your pleural, in your thoracic cavity. Addition of air or addition of fluid. So pneumothorax, hydropneumothorax or large pleural effusion. So this is our decision chart. Now, after seeing this decision chart, whenever we want to state our diagnosis, stating the diagnosis in a correct way is also very, very important. For example, if they have a right-sided disease, we have to first say which side it is, left or right. After saying the left or right-sided disease, next it is important whether it is a whole lung disease, it is an upper lobe disease, or it is a lower lobe disease. So that forms your anatomical diagnosis. So second is the pathology. What kind of pathology it is? Is it a consolidation? Is it a collapse or what else? So that is your pathology. Next, we have to say what is the likely etiology. Is it likely due to tuberculosis? It is likely due to malignancy or likely due to something else. And lastly, always remember to mention associated problems or comorbidities. For example, in the example cited here, if my diagnosis is right upper lobe consolidation due to TB with anemia, here right upper lobe is my anatomical diagnosis, consolidation is my pathological diagnosis, due to TB is my etiological diagnosis, and associated problem anemia is my comorbidity. So this is how we will state the clinical diagnosis. Now after this, I would just like to put forth few case scenarios, and I would just request for active participation from everyone so that anyone can unmute and anyone can give the diagnosis so that we will have a kind of interactive session. I've just taken few case scenarios. Is it fine, madam?
Rajalakshmi?
Yes.
Yeah.
Definitely
So,
yes.
shall I start with the first case scenario, madam? Yes. So now I start with my first case scenario. As you can see, this is a young man. He has a unilateral disease. There is reduced movements on the left side. On examination, my left hand is moving less. There are reduced movements on the left side. Also, what additionally do I have? There is deviation of the trachea to the left. Okay, and as I can see, there is flattening, some flattening on the left side. And on auscultation, I get reduced breath sounds on my left side. On eliciting the history further, the patient gives history of symptomatology since 6 months duration. And there was a history of being treated for pleural effusion and history of pleural tapping done 6 months ago. So this is my case. Would anyone like to volunteer and try? Yes.
Pleural thickening.
Yes, very good. Perfect. Perfect. Awesome. Awesome. Yeah. So again, as sir has said very aptly, pleural thickening. Now, how have we reached the diagnosis? It's a unilateral disease, correct? That we came to know. Second thing is it is associated with volume loss. Okay, so unilateral disease with volume loss. So now in this, auscultation will be the deciding factor. If it would have been bronchial breath sounds, my diagnosis would have been fibrosis. Now there are reduced breath sounds. So there are only two possibilities. Either it can be collapse with obstructed bronchus, or second thing is there could be pleural thickening. Now how do I distinguish between the two? Here my history becomes very, very important. Since the patient has given history of pleuritic chest pain and a pleural tapping done, there is definitely a pleural disease. And pleural disease associated with volume loss is nothing but pleural thickening. So perfect. Okay, thank you. Moving to the next case situation. So here our diagnosis is pleural thickening. So now here is the second example. So as we can see here, there are reduced movements present on the right side. Okay. So right side is the pathological side. The next is trachea is shifted and shoulder is drooped. This all is there on the right side. So right movements are reduced, shoulder is drooped and trachea is shifted to the right side. And on auscultation, there are fine crackles in the right upper lobe areas. So would anyone like to volunteer with the diagnosis? Yes. Yes, yes, sir.
So there is a
Pancreas tumor or something?
Pardon me?
Is it a pancreas tumor?
I again repeat, there are crackles in the right upper lobe areas. First, there is a unilateral disease. Disease is present on the right side. It is associated with volume loss findings. And I'm getting crackles in the right upper lobe areas.
Smooth wall cavity fibrosis.
Yes, yes, yes.
History also Dr. Amar Pawar has written right-sided collapsed lung. If it is upper lobe area, we have to stick to the anatomy.
Yes.
So we should stick to right upper lobe and not call it right lung or right sided.
True, true. That is a
Small,
specifically
yeah,
is written
just the
in
small
upper lobe.
nuances.
Right. So correct. So that is a right upper lobe pathology. So basically it is a right upper lobe. Now my differentials are, because it is volume loss, it is collapse or fibrosis. But since I'm not, it is a right upper lobe fibrosis. So right upper lobe fibrosis. Now coming to example 3. Now here I have reduced movements on the left side. Trachea is central. There is no volume loss. There is no volume gain. So it's a unilateral disease, but there are no volume loss and volume gain findings. I'm getting tubular bronchial breathing in the left mammary area. Only bronchial breathing in the mammary area. That is my only finding which I am getting.
Left upper lobe consolidation. Left upper lobe consolidation.
Yes, perfect, perfect. So it is a pathology of the left side. There is no volume loss or volume gain. So it is a consolidation, and there is bronchial breathing, which again supports consolidation. So here, As I have said here, the X-ray shows a lingular consolidation. There is Silhouette sign positive. However, for clinical purposes, if we do not have an X-ray, we will not be able to say clearly because lingula is a very small area of the lung. So finding or eliciting lingular pathology clinically is not possible. So for clinical purposes, we can say that it is a left upper lobe consolidation. Very correct. So moving ahead to the next example. So there are reduced movements on the left side. As we can see, the left shoulder is elevated and I'm getting dull node on the left side.
Some left tumor.
Yes.
Lobe,
Again, I have just
Not
forgotten to
etiology.
add a line here. I'm getting reduced breath sounds also on the left side. Okay. So that is one additional thing which I would like to say. Reduced movements, elevated shoulder, dull node, and reduced breath sounds.
If even
Yes, yes. Correct, perfect. So unilateral disease with volume gain findings and reduced breath sounds goes in favor of left-sided pleural effusion. This is the X-ray of the patient. Coming to next example. Now patient has reduced movements with signs of volume loss on the right side. So movements are reduced on the right side. There are volume loss findings on the right side with a dull node present. Now I'm getting amphoric bronchial breathing on the right side. And patient has history of treated hydropneumothorax, which is treated with an intercostal drain. And now this is the patient's clinical findings. So what can be my clinical diagnosis?
fibrosis,
Okay, volume loss, but there's history of pleural disease also.
Bronchopleural fistula.
Yes. Perfect.
Right side.
Perfect. Yes, perfect. So bronchopleural fistula with additional pleural thickening. Why? Because there are findings of volume loss. Okay, and amphoric breathing going on a background of treated hydropneumothorax goes more in favor of a bronchopleural fistula. So this is the X-ray of the patient which shows a loculated hydropneumothorax. And this is a CT which is confirming the same. Coming to next example, I can, So this patient has signs of decreased movement and volume loss on the right side. Movements are reduced on the right side. There are volume loss findings. Shoulder is drooped. There is deviation of the trachea to the same side. Now, there are decreased breath sounds in the right upper lobe areas. And then additional finding, which we can see in the lower picture here, is the significantly dilated veins over the right supraclavicular region. So, what could it be?
tumor,
Yes. Which sided tumor?
Right
so
upper
steel phenomena is happening. It can be any pan-cause tumor. Or
Yes. So, basically, any right upper lobe mass. And in addition, with some syndrome, right upper lobe mass with
Horner syndrome.
Horner syndrome.
Okay, but that
Horner
is
syndrome.
probably not available. But as we can at least see,
Superior
there are
vena cava syndrome.
superior vena cava obstruction.
superior vena cava obstruction, right? Yes. So my clinical, hello? Yeah, so my clinical diagnosis will be what? I will not be able to say mass clinically, no? So patient has collapse with obstructed bronchus findings. So it is a right upper lobe collapse with obstructed bronchus due to an endobronchial mass most likely with superior vena cava syndrome. And this is the X-ray of the patient which is showing the right upper lobe mass, and it is also showing something called a golden S sign. That is fissure pulled up because of the mass. And this is my last example. So maybe a little difficult. There are decreased movements on the left side. There is left shoulder drooped, but the trachea is central. Now I'm getting cavernous bronchial breathing on the right side and crackles in cavernous bronchial breathing in the right intraclavicular area, and there are cavernous breathing in the left intraclavicular area and crackles in the right intraclavicular area. I again repeat, there are reduced movements on the left side. Predominant volume loss signs are seen on the left side with shoulder drooped. However, trachea remains central. On the left intraclavicular area, there are cavernous breath sounds, and the right intraclavicular area, there are just crackles. Yes.
Lung abscess?
Okay, means a cavity you want to say, right?
Yeah.
A cavity. Correct. So left upper lobe cavity can be due to lung abscess. Correct. Anything else? Anything on the right side?
Right side upper lobe fibrosis.
Yes, perfect, perfect. So this is an example of a bilateral disease, but it is appearing as unilateral because there is unequal volume loss. So there is a left upper lobe cavity with right upper lobe fibrosis. Now there are predominant volume, see the left side is moving less. So actually both sides are pathological, but the side which moves left is the primary, side which moves less is primarily the pathological side. That is why we will say left is pathological. Therefore, the moment of the volume loss findings will be interpreted as a left-sided findings. Since we are getting cavernous bronchial breath sound, there has to be a cavity. But right side also we are getting crackles, so there has to be fibrosis. Now, because it is a bilateral disease, the right-sided pathology is pulling the mediastinum to the right. The left-sided pathology is pulling the mediastinum to the left. That is why the trachea remains central. So this is an example of a bilateral disease. Yeah. That's it. Thank you so much.
Thank you so much, Dr. Ketaki. I think the last few case presentations were really, really useful for just to quickly go through what we have heard. Sometimes when we hear to the sessions, we think that we know these things, these are our basics. But when you bring it up in the mode of case presentation, I think that helps a lot. Rajan, are you there?
Yes, ma'am, we can hear you.
I'm here, but I'm
Yeah.
having some power outage in one half of my house. That's why I'm switched the video off. But this session of Ketaki reminded me of my first week doing MD with Dr. Joshi in Nair Hospital, and it's just a great refreshing for me also, and to all.
We lost you. I think your network might be an issue. Anyone wants to add or comment or like to unmute or speak or something? We are getting a lot of comments in the chat about the session. Dr. Ketaki. I hope this was a revision for everyone.
Any questions? Queries, doubts?
Someone has asked, Dr. Sublakshmi has asked, can you repeat MMRC?
Yeah, sure. Yeah, so MMRC grading. Yeah, am I audible?
Yes,
Yes.
So MMRC grading that way is divided. There are many gradings, but the one which we commonly use for our quantification of dyspnea is the MMRC grading. So that is also called a Modified Medical Research Council. Now it is divided into 5 grades from 0 to grade 4. Now it depends on the effort tolerance of your patient. So how to remember it as easily MMRC grade 0. So 0 we can remember as O. So O for only. So MMRC grade 0 is only on strenuous physical exertion. MMRC grade 1. 1 is finger pointing like this. So that is what? Uphill. Okay. So dyspnea on walking uphill. So that is MMRC grade 1. Now MMRC grade 2. 2 means, how do you remember? It as 2 people walking together. So when the patient walks with his or her peers, the patient will lag behind because of breathlessness. So that is grade 2. Grade 3 is, you remember it as by 3 digits. So 3 digits are 100, 100. So on walking 100 meters, if the patient gets breathless, it is MMRC grade 3. Grade 4 is, remember, as patient will be on 4s. That is, patient will be so breathless that patient will acquire tripod position and patient will be too breathless to either even stand up or sit down. So that is grade 4. So almost dyspnea at rest. Yes. Yes.
I can't see any more questions, but Dr. Deepak has mentioned that when we go for home care, relying on clinical examination is of mighty importance. So this session is very, very relevant for most of us who works on the field and where you can't expect any investigations to be done nowhere in the near future also. Thank you so much for that. Raju?
So there's another chat, Sridevi. Can you hear me?
Oh, I think so. Yes, I can.
So there is a chat by S. Subbalakshmi about scenario 6. There was a bronchial sound. Ketki, can you just go back there for a revision on scenario 6?
Yeah, just 1 second.
Yeah. Yes, the slides will be shared, Madam. Rajashri, Madam, it will be shared.
Yeah, so this is a scenario 6. Yeah, do I read it aloud?
Yes.
So,
Yeah. So
yeah, this is a scenario 6. So in this, we have a patient which has signs of reduced movements on the right side. So right side is moving less. There are signs of volume loss also on the right side. That is, there is shoulder drooping and deviation of the trachea to the same side. And if you can see very clearly, there also seems to be some flattening on the right upper lobe area. Then on auscultation, there are reduced breath sounds in the right upper lobe areas. And as we can also see that there are dilated veins present on the chest wall. And hence, here my diagnosis will be, first of all, right side is moving less. So, and the findings are in the upper lobe area. So the anatomical diagnosis will be pertaining to right upper lobe. So that is anatomy. Now, what is my pathology? Since I'm getting volume loss, it has to be a collapse or a fibrosis. Now, how do I differentiate? Since I'm getting reduced breath sounds, that is why it will be a collapse. So my pathological diagnosis will be right upper lobe collapse with obstructed bronchus. Then, in addition, patient also had dilated veins with a clinical background of suspicion of malignancy. It can be said as superior vena cava syndrome. So hence my diagnosis is right upper lobe collapse with obstructed bronchus with SVC syndrome. Yes. Hello? Hello?
Yes.
Yeah. Yes, madam.
I think there is another question about wheeze and bronchi.
Okay. So basically, I would just like to clarify that wheeze and bronchi are not very different from each other. They are based on the same concept. Okay, whatever we can hear with the stethoscope simply, that is bronchi. And sometimes the patient is so breathless and the bronchi are so severe that they are audible without a stethoscope. The patient sits in front of you and you can feel a squeaking sound. Patient makes that kind of sound which is seen. That is the sound which is audible even without stethoscope. That is wheezing. So we say that the patient is wheezing and I am able to auscultate and I am able to find bronchi. Okay, so wheeze can be a clinical symptom also because it is something that a patient will complain of. कि जब मैं सांस लेता हूँ तब घर या चू 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 आवाज आता है. So that is basically a symptom. And bronchi is a clinical finding. So wheeze is a symptom as well as sign which the physician sees, whereas rhonchi is a clinical sign.
And both signify airway obstruction. Although everything that wheezes is not asthma, it's definitely some kind of airway obstruction. So it could be foreign body, it could be tracheal collapse, any upper airway obstruction, severe, critical. But wheeze is often a symptom. Patients will come to you with that. Rhonchi is something you elicit through the stethoscope.
Yes, madam. Very well. Thank you, madam.
Any more questions or comments? Deepak Sudhakaran has asked, in pulmonary edema, anatomically fluid collects within the alveoli. So, Deepak, you can also have interstitial edema. You can have alveolar edema. So, but when you hear the crepitations, it's because air is passing to the alveoli. Interstitial edema will be seen as fine crepitations, which is velcro rales, and coarse crepitations is pulmonary edema or alveolar edema.
Thank you, ma'am.
Most welcome. In the state of Maharashtra, we are all used to saying Kolhapuri chappals that cause coarse crepitations. I'm not sure everybody has worn or seen a Kolhapuri chappal, which is why Ketaki changed it to new leather shoes. But
Yeah.
Kolhapuri chappals are the best description of coarse crepitations.
True.
Ma'am, I have one doubt. In this case of situations of COVID now and post-COVID complications and all, which is happening on long term, what is the findings which you're preliminarily finding? Like what are you getting? Is it some signs of fibrosis, lung signs?
You're talking of pulmonary law symptoms? That's what you want to focus on?
Yes, ma'am.
Yeah. Okay.
Yes.
Ketki, we are having a session on post-COVID fibrosis also.
Yes.
But
Yes,
just to answer, Ketki, please, you can go ahead.
So basically, it depends on the severity of COVID. If it is mild to moderate COVID, then we are generally not seeing any predominant pulmonary findings. But if the patient had a history of severe COVID that required oxygen, maybe that required NIV or invasive ventilation, in that severe kind of COVID, there is a post-COVID sequelae which sometimes develop that is very similar, that is post-COVID pulmonary fibrosis. The clinical signs and symptoms are very similar to ILD. So that is basically a post-COVID ILD. So patient will have clinical signs and symptoms like patient can have clubbing and there can be fine velcro rales on auscultation. So basically that generally presents with the ILD-like picture. So findings will be very similar to ILD.
All right, ma'am. Thank you so much.
Thank you.
Any other questions or queries? There's something else on the chat. Crepitations and crackles are same. Yes, that's what is used in the US and the UK, and we use both interchangeably.
One more doubt. How is there anything which any literature on like how long does it take for clubbing to happen? Now we said in post-COVID conditions also sequelae also clubbing may occur. So is there an approximate time so that like we can have an estimate like, okay, he's been having this disease since so long and it was undiagnosed for so long. Is there a timeline like that?
Basically, there is no particular timeline as such, but generally clubbing signifies in majority of the cases a chronic thing that has led to hypoxia. So basically any chronic hypoxia generating condition, or sometimes in rare situations, acute conditions like lung abscess, in there is significant suppuration. So basically two primary mechanisms of clubbing are either there has to be a hypoxia or there has to be suppurative, that is pus forming conditions. So in these two conditions, it can be either acute or chronic, but generally we see it in chronic respiratory conditions.
There is another question, Ketki. Bajalla has asked to go over dry and wet productive cough. I've not understood the question. What exactly do you want to know about it, sir? You can unmute and ask us.
All right. Thank you very much, ma'am, for the presentation. Yeah. So I just got lost along the way because my network was giving me problems. So I please wanted you to just go over like some of the causes of the dry cough and the productive cough.
Okay, great.
Yes.
Go ahead, Ketki.
Yeah. So dry cough is basically seen in generally conditions which affect two components of your respiratory system. That is, we can remember it as pleura and interstitium. So whenever there is involvement of these components, generally the patient has a dry cough. So it is seen in conditions like pleurisy, inflammation of the pleura, pleural effusions, pneumothoraces, hydropneumothoraces, or bronchopleural fistula. So these are pleural conditions which will cause dry cough. And the next component of the respiratory system which causes dry cough is the interstitium. So basically any form of interstitial lung disease like IPA, hypersensitivity pneumonitis, sarcoidosis, so any ILD, that will also cause a dry cough. Generally, a productive cough is seen in conditions that involve either the airways or conditions that involve the parenchyma. This is how madam has taught us to remember. So airway disorders, for example, either bronchial asthma, chronic obstructive pulmonary disease. Okay, all these will generally give rise to a productive cough, which is productive for mucoid sputum. Parenchymal condition, for example, it is pneumonias, lung abscesses. Generally, they will have a productive cough associated with a mucopurulent sputum.
All right. Thank you so much, ma'am.
I think there are no more questions in chat. I think maybe we can wind up today's session. Thank you so much, Raju, for introducing Kate to our group. I'm not sure whether my network, Raju, am I audible?
Entirely my pleasure. When I first decided, discussed with Sridevi and decided, I thought it would be very basic, but I also realized that sometimes going to basics is a great way to start learning, to go back to a clean slate. So I just hope that, this thought of mine has been accepted and has gone well with all of you. It was just something I took a chance because I know how much I had enjoyed learning this and how much I enjoy teaching this to, every new medical student. So hope to see you all next Wednesday. All the faculties are actually from teaching hospitals. So like I said, they'll be updated and abreast with all the latest developments. So thank you for joining in these large numbers, and over to Pallium.